Sarah is traveling today, so I'm Emma Tillman. I'm from Indiana University, and I'm going to facilitate with Sarah's absence. And I have the pleasure today of introducing a good friend of mine, Kelly Caudle. Kelly received her Pharm.D and Ph.D. from the University of Tennessee Health Science Center in Memphis, where her Ph.D. Dissertation was on mechanisms of antifungal resistance. Then she transitioned to work in pharmacogenomics for the past decade. She's been studying pharmacogenomics, working with the Clinical Pharmacogenomics Implementation Consortium, where she's now the director. And this is at St. Jude, and she's an associate member of St. Jude. And with that, I will turn it over to Kelly to teach us about pharmacogenomics and CPIC.
All right, great. And thank you first for this opportunity to talk to this group. And so I am going to talk about CPIC. It's what I know. But it's the Clinical Pharmacogenetics Implementation Consortium, like Emma just said. And what I really hope to show today is really how we've come together as a community to really facilitate the implementation of pharmacogenomics really through this global collaboration. I know a lot of you probably understand this concept, but we can give, we talk about pharmacogenomics. What is pharmacogenomics? And it really is, we have a group of people, a group of individuals. We give them the exact same drug, same dose, and a lot might have that effective cure that we were hoping for. Others, they may not have. It may be non-effective. And then there'll be a smaller subset that have, a severe toxicity or side effect to the drug. And what's not shown here is, I think, there's a step up, I think, from that severe side effect, and where the patients are still taking the drug, but they're experiencing some type of side effect, and they stop taking the drug because of that particular side effect. So even though we do see severe, and those are the ones we may worry about the most, I think, really trying to avoid getting a patient on the right drug in the right dose so that they don't stop taking their medication because of an annoying side effect. And so this is what pharmacogenomics is. And we've known about pharmacogenomics for actually quite a while. And this is a quote from Dr. Francis Collins. In the very near future, primary care physicians will routinely perform genetic tests before writing a prescription because they will want to identify poor responders. And so this is I know many of you have probably seen this. It's one of my favorite cartoons, partly because it involves a pharmacist, but it's a patient handing a sequence over to their pharmacist for their pharmacist to select, the right drug and the right dose for this particular patient. So this was almost 25 years ago that we were kind of starting to understand that there may be some link between our genetics and drug response. And it was in 2015 where President Obama, during his State of the Union address, announced that he was launching this precision medicine initiative. And so I want to read this quote from him because it in some ways it makes me laugh, but in some ways it's a great way to optimistically look at where we could be one day. And it says, doctors have always recognized that every patient is unique, and doctors have always tried to tailor their treatments as best they can to individuals. So you can match a blood transfusion to a blood type. That was an important discovery. What if matching a cancer cure to our genetic code was just as easy, just as standard? And here's the important part. What if figuring out the right dose for a medicine was as simple as taking your temperature? And here we are almost 10 years later, and of course, it's not even close to being as simple as taking your medicine. I mean, your temperature, but maybe it should be. But the truth is we don't really know how to use all that genetic data to really tailor therapies because we don't know how to use it. We don't know. We look at this information, the genetic information. You see that there's evidence that really supports some type of drug phenotype for a particular gene variant, but you really don't know how you would act on it. And this was definitely the case back in 2012, 2015. Our patients are also starting to see and understand what pharmacogenomics is. And I think this has been for pretty much the last 10 years. Because we're seeing a lot more about pharmacogenomics in the general media. And actually, this is a study back in 2016 where they surveyed healthy adults that gave their reasons for taking part in programs offering genomic sequencing. And you can see that 81% of the patients took part in the study so they could learn about their response to medications. And so now that Precision Medicine Initiative is now called the All of Us. I know many of you are probably very much aware of this program. where they're inviting 1 million people across the US to help build one of the most diverse health databases in history with data linked to electronic health records. So I think we're going to hear and be seeing a lot more new evidence that's generated from this data in the near future. But one thing that they're doing is that they are providing back to patients a genetic test result for pharmacogenes. And so these patients will be getting this information. They'll have this information, and I believe that many will take these to their physicians or pharmacists to help them translate it. And it would be, in a lot of ways, dangerous for our clinicians to ignore these results. And so I'm going to talk a little bit about, adverse drug events here, but there is that flip side of efficacy as well. But I think this one I have the better stats on. But when I say adverse drug event, what I mean is harm caused by appropriate or inappropriate use of a drug. So this also includes overdoses, provider error, non-adherence, and of course, incorrect dosages, but also includes probably some variations in drug response based on a patient's genetics. But the FDA classifies adverse drug events as one of the major causes of morbidity and mortality, an important driver in healthcare cost. Adverse drug events account for about 5% of hospital admissions in adults in the US, with about 15% in patients with multimorbidity, probably because they're taking multiple medications. And about 10 to 20% of people in the hospital actually do experience some type of adverse drug event. Annual cost of adverse drug events is really hard on our healthcare system, with about $4 billion in the US. But there is some evidence that really shows that the use of pharmacogenomic test results can prevent about 20 to 30% of adverse drug events in patients with high-risk phenotypes, and can actually considerably reduce adverse drug events associated deaths. But one thing I like to point out every time I talk about pharmacogenomics is that there are many factors that affect drug response. A lot we know about, a lot we don't. We all know about those drug interactions, reducing doses based on renal and liver function, but there really can be a lot of things that causes that variability that we see in patient drug response. So pharmacogenomics is really just a piece of this puzzle, but it also impacts quite a few people. And so this is a table showing you the proportion of people who carry at least one actionable pharmacogenomic variant. Now, I'm going to, throughout this presentation, I'll probably say high-risk phenotype or actionable phenotype, but I really mean the same thing. When I say this, really, we define this as a genotype result that necessitates a change in drug dose, or drug monitoring. But you can see from this table here that really, depending on how many genes are evaluated within each study, probably the population of patients that were studied, we see anywhere from about 91% up to almost 100% of patients in these studies that have at least one of those actionable phenotypes. This is data from St. Jude. It's from 2022, so our numbers have changed a bit here. But this is the proportion of St. Jude patients that have high-risk phenotypes. So we've got a program going on for about a little over 10 years, where we've genotyped. I think back in 2022, we were at about almost about 6,000 patients, and we've genotyped for 13 pharmacogenes. And 95% of the St. Jude patients have at least one high-risk phenotype, with a third having two, another third having three, about 14% with four, and actually several having, 5 or more high-risk phenotypes, with only about 5% not having any at all. So this is incredibly important for our patients. It's measurable, and it's something that we could definitely do to help reduce toxicity to medications. I love this figure, so I'm going to show this again later and kind of show you how I think about this, maybe from a guideline development standpoint and the way we use it here at St. Jude. But this is the figure that we've seen through the NIH and some other websites, where they're talking about a learning health system. And it's really a health system in which internal data and experience are systematically integrated with external data evidence, and that knowledge is put into practice. But you're also continually, assessing these processes and training to create some type of feedback cycle for learning and improvement. So we always want to kind of improve. So, we implement something, we learn from that implementation, that goes back into our data, goes into the evidence, and then, of course, we can then implement that back into practice. But I've highlighted here this portion here of taking this evidence and getting into practice. This is probably one of the largest rate limiting steps, especially after discovery of some type of intervention or some type of association with a drug phenotype. So how do we get from the evidence to actual clinical practice? So this is a survey that we conducted now a little over 10 years ago. where there were physicians, pharmacists, clinical pharmacologists, that we asked, what are the three most challenging aspects of the implementation of pharmacogenetics into clinics? So we were pretty much asking them, why aren't you implementing pharmacogenomics? And 95% of the respondents selected this process required to translate genetic information into clinical action, with the next two responses being genotype interpretation. So how do you use genotype information to really impute that phenotype? And they also wanted to know, how do you provide recommendations for selecting the drug gene pairs to implement? And so I'm going to show you how we've overcome this barrier a bit. Test cost, it's kind of funny to me that test cost was really kind of on the lower end of this, and reimbursement, because it certainly wasn't very widespread 10 years ago. So it wasn't really a big concern because a lot of people weren't testing, but now it is. I think reimbursement may be one of our bigger barriers that we still need to overcome. And we are working through that as well. But let me tell you a little bit about how we've overcome these first couple of barriers. So this is where CPIC came along. So again, we're the Clinical Pharmacogenetics Implementation Consortium. We were formed in 2009 as a shared project between Stanford and St. Jude. We were started by Mary Relling and Terry Klein at Stanford. And we really have grown to over 700 members. I think when I started working with CPIC in 2012, we had 60 members, and now we have over 700 members of clinicians and scientists, over 538 institutions, and 48 countries. Sorry, I got tired of updating that number. This is why it's a greater than 538 institutions, but I know we're greater than that number now. And we stretch across 48 countries. But our main goal really is to provide freely available, evidence-based, and updated pharmacogenomic clinical practice guidelines. We've been continuously funded through the NIH since about 2012. We now have 26 guidelines, and the number is kind of off a bit just because we have updated a lot of these. So I think we have in all about 50 publications that are guidelines. I think we're about to update our TPMT NUTI 15 guideline for the fourth time. So as evidence continues to evolve and is published, we have to kind of address this in our guidelines. And so we do update these guidelines on an ongoing basis. But right now, our guidelines cover 25 genes and over 90 drugs. I will tell you that we just submitted 2 guidelines they're both in review right now. So keep your fingers crossed these are published, but this will increase our numbers of the genes by at least 5. So we're going to have quite a few genes and guidelines. All right, so CPIC, as I said, is a global organization. You can see we've got members from all over the world. And the other thing I'd like to point out here is that we do have our guidelines, also have a lot of international representation, with most of our guidelines having 2 or more international authors. So you can imagine that conference calls for the CPIC guidelines can be complicated, especially if we have individuals on the Pacific Coast, the East Coast here in the United States, Australia, Japan, Africa. I mean, it really is difficult to get people together, but I feel like our members have done a great job of calling in at 3 o'clock in the morning because they really are dedicated to helping us get these guidelines put together. I'm not going to go through the CPIC process, mostly because we have a publication on this and it may bore you. But really, we've got a publication that we published in 2014 where we compare our standards for writing the guidelines to the IOM's clinical practice guidelines we can trust. There's a whole bunch of standards there that we follow pretty much to the T. And in this paper, we do compare it to those standards. But one thing I'd like to point out here again is because, and just to kind of emphasize this power of collaboration and community. Each guideline has a multidisciplinary, group comprising of a variety of scientists and clinicians. They have to have a track record and publication or expertise in that specific topic area. We also have implementers, maybe someone who's implemented a particular gene and that can really help us understand, really the feasibility of our recommendation and how this might affect actually getting this implemented into like an EHR. We also, and as I said, we have international representation, but one thing that we have to be very careful about is conflict of interest. And I do think we do a pretty good job at managing the conflict of interest for each one of our guidelines. As you're probably aware, this has become pharmacogenomics testing has become a big for-profit thing. We have a lot of commercial laboratories that are testing big panels of genes. And so we really do think it's really important that we have evidence-based guidelines without these conflicts. So what does a CPIC guideline do? So CPIC guidelines, the one thing to note about a CPIC guideline is we do not discuss the merit of actually doing the test. We are assuming that the patient or the physician has already ordered the test and that they have this information at hand. And so your patient comes in, you see that they're CYP2C19 star 1 star 17, and then we would get guidance on what you would do with that information. But here I'm showing you TPMT. We are at St. Jude. This is an important pharmacogene for our patients here. Each guideline has two main tables. They're not always table 1 and table 2 because our guidelines have grown quite a bit over the years. Originally, it was usually one gene, one drug. Now we're really dealing with multiple genes and multiple drugs, so our tables have definitely expanded. But each one of our guidelines has at least these tables, a genotype to phenotype translation table, and then a recommendation table. But you can see from this, this figure here that our recommendations are based on that phenotype. So very important part, and a lot of people don't understand the amount of work that really goes into assigning phenotype based on that genotype. Actually, I think we've got a 50-page SOP that walks us through this process. This is done by an individual group, not necessarily always the guideline authors, where we assign that phenotype based on genotype. And then again, it's really important we get that phenotype right because that recommendation is based on that phenotype assignment. And you can see here, so for example, if your patient was a TPMT star 3 star 3, we would assign this as a TPMT poor metabolizer, and our recommendation would be to decrease the dose. We have systems for grading not just the evidence as high, moderate, or weak, but also a system for grading the recommendation as strong, moderate, optional, or no recommendation. So this particular guideline for that TPMT poor metabolizer, we did give this a strong recommendation. You're going to hear a lot about CPIC levels. And so the CPIC, what we like to do is assess really that clinical actionability. And we assign levels to these gene drug pairs. So actionable, an A and a B are considered what we call actionable. Not actionable would be assigned a C or a D. So an A, we've given it a strong or a moderate prescribing recommendation. B is where we've given it an optional prescribing recommendation. C is where we've reviewed the evidence and we don't think really there's anything you can do based on this information. So we give this a what we call a no recommendation or a CPIC level C. CPIC level D is generally where testing maybe is rare, but there's still no prescribing recommendation there. And we probably in most of these cases have not done a full review of the literature. You can find information about those types of genes in Pharm.GKB, which is a pharmacogenomic database, really knowledge base. But here's a list of all of our guidelines. I know this is a busy slide, but yeah, as I said, we have 26 guidelines, 28 hopefully soon, that covers 25 genes and over 90 drugs. And so if you look over here on this right-hand side, you'll see that we have quite a few of what we call CPIC level C. You know, we listen to our community, we listen to our members, and a lot, you know, we generally, you know, 5-6 years ago, we may not even pursued a guideline if we didn't think there was enough evidence for it to be actionable. But we were really being told that a lot of these genes, OPRM1 is on pain. You'll see this one on pain panels, SLC6A4 and HTR2A. You see these on psychiatric, gene panels. And so our users were like, hey, we need some guidance on, do we ignore these or do we use them? How do we use them? And so this is why we've started including maybe these lower level evidence genes on our guidelines. And that's where we may assign it a CPIC level C. So it goes through the same evidence review as all our other genes. But at the end of the day, our authors decided either the evidence was too weak or we didn't think it was actionable. We just didn't know how you would act on it. And so it becomes a CPIC level C. That's not to say that in 3 or 4 years when we have additional evidence that this may not change, but that's why we're continuously monitoring the evidence to make sure that nothing would change our recommendation for the guidelines. So I'm going to brag a little bit about CPIC. I think one of the things we really struggle with is dissemination of our guidelines. The most feedback I get is that, hey, I took the CPIC guideline to one of my physicians and he had never heard of CPIC. Well, that's actually probably fairly common. But within the pharmacogenomics world, we certainly have become that authoritative resource for pharmacogenomic implementation. And so this was a figure from our recent grant. where we did a quick PubMed search looking for anything, any type of paper where they were doing some type of pharmacogenomic data analysis prior to implementation. Maybe they're doing a clinical implementation of certain gene drug pairs, or they were using or developing some type of tool for implementation. And you can see from all the papers we found, 67% of them were using CPIC, with 21% of these were actually outside the United States. CPIC guidelines are actually highly cited as well, with over 13,000 citations for our guidelines together. Another good stat we can look at here to see if they're being viewed is these are looking at how often these are viewed on these websites. You can find the CPIC guideline for free on the Clinical Pharmacology and Therapeutics website, CPIC website, and also on Pharm.GKB. Kind of mentioned Pharm.GKB a few minutes ago. It's a great knowledge base where it's got a lot of great information. They curate pharmacogenomic evidence, but they also curate pharmacogenomic clinical practice guidelines. And also drug labeling. So it's really become a really great resource, but you can also find these CPIC guidelines there as well. So when we were looking at the stats, we had to get stats from all three of these places. And you can see that our guidelines are actually being cited, are being viewed, this SSRI guideline almost over 100 and almost 130,000 times, with even some of our lower level guidelines being still viewed and utilized, up to 40,000 times or more. This data actually lacks the PubMed Central. So you can also, of course, we're NIH funded. You can find these guidelines in PubMed Central. But unfortunately, they were unable to provide stats. So I expect these numbers are actually a bit larger. So CPIC guidelines are being endorsed by professional societies and cited in genomic resources. We worked really hard to get these endorsements in the thought that this would help with dissemination. I already talked about how they're in PubMed Central. This is the genetic testing registry. This is a place you can go in and you can put in, for example, TPMT, and it will pop up and it will show you all the laboratories that are testing TPMT. And you can see over here, this is an outdated slide, I apologize, but you can see that that CPIC is being cited as practice guidelines within that gene summary. We are also being endorsed by ASHP, which is a very large pharmacist organization. They actually have links to our website right from their member pages. And then we are also endorsed by ASCPT, or the American Society of Clinical Pharmacology and Therapeutics. We do publish in their journal, Clinical Pharmacology and Therapeutics. And we have an agreement with them so we can post these almost immediately after they are posted online to our websites to really help with that dissemination piece. And we are actually now in ClinGen. So ClinGen is an authoritative central resource that defines clinical relevance of genes and variants for genetic diseases. Really does not have a place for pharmacogenetics in there. And I'll talk a little bit later about our work with ClinGen and the work we're trying to do to get our guidelines a bit more integrated into the ClinGen database. Our guidelines are also being cited in clinical practice guidelines. This is from NCCN, looking at pediatric acute lymphoblastic leukemia. And you can see they've got our guideline reference down there, and the words here in this table are actually pretty much word for word what is in the guideline. This is not the only guideline. We see them in the COG protocols where they recommend TPMT and NT15 testing. I believe that CYP2D6 is actually in NCCN guideline for pain management. So these are actually being cited slowly in clinical practice guidelines. In my opinion, though, this is where we need to be. I think you have a physician, who maybe a cardiologist. He's only going to use the disease specific guidelines that he utilizes as part of his practice. So I think a big barrier for us is getting this information into those larger disease specific guidelines for our physicians to really start understanding what pharmacogenomics is and to start ordering the test and utilizing it. But we've done this very nicely here at St. Jude. We've got a pharmacogenomics program, and of course, I'm going to go back to that learning network figure here in a minute, where our program really is based around discovery and translational research, clinical implementation, and professional education. Actually, all these resources and a lot of resources are actually, and I forgot to put the link here, but you're welcome to email me for it, right there on the St. Jude website where we discuss our program. As I said, we've already implemented about 13 genes here at St. Jude. You can see it was done over time. We didn't just throw all these genes in the medical record. A lot of this was because we needed to really figure out how the best practices would be to get this information into the electronic health record. How do we write these post-test alerts? How do we best communicate this to our physicians? So we certainly learned a lot over time, but now we've got up to 13 genes. I think we're working on a couple of more right now to get integrated into our EHR. So here's that learning health system figure again. And I think what we've been able to do quite nicely here at St. Jude is really be able to take that research and kind of decrease the time that it takes to get a finding into a guideline and also into practice. So here's an example. Our original TPMT thiopurine guideline was only really TPMT. NUD-T15 was not really known at the time, I think, when we originally did the guideline. But in 2015, Dr. Yang and Dr. Relling here at St. Jude found, published a paper that said inherited NUD-T15 variant is a genetic determinant of mercaptopurine intolerance in children with acute lymphoblastic leukemia. And it really only took about 3 years for us to get a little bit more evidence to support this, of course, but then to integrate this right into the guideline. But what I want to point out too is that we also were able to integrate this right into our electronic health record really before we were able to get through the guideline process. The guideline process takes about a year from start to finish through evidence review and discussing the recommendations, and then of course going through the publication process. So it takes about a year, but because this was discovered here, we had the knowledge and the people to do this and to come up with a recommendation. We were able to implement this almost immediately when we realized that this was definitely an actionable recommendation. And in fact, we just published their paper really looking at what the combination of TPMT and NUD-T15, if your patient was IM or an intermediate metabolizer for both, we actually have new guidance on what type of dosing these patients should be. So this guideline is actually going to be updated here very recently, or very soon, sorry. But we've already integrated this into our EHR. Our patients are already getting these updated dosing recommendations. And actually, if you go to the CPIC website for this particular guideline, we actually have some guidance at the top of that page as well. So we do try to update this, through our website, but here at St. Jude, we were able to do this almost immediately. And of course, we're going to get feedback from this. We'll be able to take feedback, maybe not from the outcome standpoint, the patient outcome standpoint, but certainly on what works well with implementing these two genes together. We'll get feedback from our physicians, our pharmacists, that can then bleed right back into the guideline. So I think it's a great place for CPIC to be located. And of course, with our collaborators at Stanford and Pharm.GKB, I think we've really put together a nice team. But CPIC does more than just this flat PDF. You've got these tables. They're great. They're nice. They look pretty. And then our recommendation table, which is really our heart of our guidelines. But I think it was 2014, we had our members come to us and say, hey, these are not very user-friendly. You got to use the PDF form. It would be really great if we had additional resources that would really help us and make it more efficient to implement pharmacogenomics at our institution, and most specifically in the electronic health record. So we formed this CPIC Informatics Working Group that was led by Michelle Roll-Carrillo and James Hoffman, where we worked with a group of people who do informatics implementers to come up with what resources do you need, what would you like to see, what would be useful for you. And so now we've got our guideline, that nice pretty PDF of our guidelines. But if you go to our website, the cpicpgx.org, you will find a lot more resources besides just a copy of the guideline. I talked a little bit about that diplotype to phenotype translation. So now we have, and versus you having to do it yourself, you have to translate it yourself. We have a table, we do it all for you. This is a lot of work for some institutions. CYP2D6 has over 150 alleles. And so it's this diplotype to phenotype translation. I think there's over 10,000 possible phenotypes or diplotype combinations. Sorry, not phenotypes, diplotype combinations. And so this really can help our implementers efficiently. It'll be one less step they have to do. And then we also have, we provide another thing that, our implementers said is, gosh, it took us months to get that post-test alert. So that alert that when a physician goes in, orders the drug, and the patient already has that a high risk alert or high risk phenotype in the chart, then they get this post-test alert that says, hey, this patient's a TPMT intermediate metabolizer. You need to reduce the dose by X amount. And they said that this takes us a while to actually come up with this wording. Could you provide some examples? And because we've done a lot of this already at St. Jude, this was actually quite an easy process, because I really start with what we've done at St. Jude, and we might edit it just a bit based on the author's preferences. But for the most part, you get a really good example of what these pre and post test alerts might look like here. And we also have other things that might be important to implement these into an electronic environment. We also have a database and an API that you can access. And I think a lot of our implementers now are pulling data directly from our API. This database has everything. It has our recommendations. It has the gene variant and allele frequencies, allele function assignments, allele definitions, of course, those diplotype to phenotype mappings, those example CDS I just talked about, and then those vocabularies and terminologies for the genes and drugs. So lots of great information in that database in structured formats. And of course, it's through a database in the API. So why, we've got these great resources, well, in my opinion, these great resources that really can help understand how to use genetic information. We've provided implementation resources to help at least make implementation a bit more efficient. But why is there still not a big widespread adoption of pharmacogenomics? Now, this is not the only reason. I could probably come up with a list of many more reasons and barriers to really adoption of pharmacogenomics. But one of them is certainly the lack of standardization. And so in 2018, we wrote a paper kind of describing 3 areas that if they were improved, this would make it more efficient to implement pharmacogenomics in the clinical, so we lack standardization in the clinical laboratory testing, reporting results, and test ordering and reimbursement. And I've highlighted here, bolded reporting results, because I think this is where CPIC has really been able to at least help with some of this. Right now, or 5-6 years ago, and I think we still see this here, that phenotype term. So those terms, normal metabolizer, intermediate metabolizer, poor metabolizer, they really vary across how they're reported in pharmacogenomic test results. And so here's an example. So we sent out a survey to several labs. I'm just showing you 3 here for the example. And we gave them a list of genes and a list of diplotypes. And we say, hey, what do you call this phenotype? And so for TPMT, this is star 3, one lab called it deficient activity. Another lab called it deficient low activity. So we're not really even these labs. And then I think if you go down the line, it was kind of all over the place of what they were calling star 3. And then another example is CYP2C19, and my gosh, this is the wild type, and we weren't even standardized on what we were calling, that wild type patient, or the patient in which we did not find any variations. One lab calling it extensive normal metabolizer, 2 labs calling it normal metabolizer, and one just using extensive. And then you'll see here too, we also do see differences in the genotype to phenotype translation. So there's 4 labs here. One lab pulled out star 1, star 17 and called it a rapid metabolizer. This is actually what we do in the CPIC guideline. But if I were to guess, and I don't know because we didn't really follow up with these labs, but this star 1, star 17, I bet are either being reported as ultra rapid metabolizer or as an extensive metabolizer. Either way, because there's a lot of controversy around this particular diplotype and where it really fits. But we really need to be standardized here, and not only in the terminology that we use, but also in that genotype to phenotype translation. And so I got a little story here. This did not happen at St. Jude, and I won't tell you the hospital it happened at, but this is where we can really show that the lack of standardization can hinder easy integration of discrete data into the electronic health record. So this happened at a leading pediatric hospital where they use Cerner for reporting and with an Epic electronic health record. And so these differences in terminology made it difficult for the integration of discrete data into the results review tab in Epic. And so accessing PGX results, it took 6 clicks and multiple browser windows to get these results, just to get this long PDF report that really, for a lot of physicians or even some pharmacists, it probably didn't make a whole lot of sense to them. And because of this, there was a serious safety event that occurred where an ALL patient received the usual dose of mercaptopurine and had severe infection, myelosuppression, and nearly died. Come to find out, this patient was a TPMT poor metabolizer, but the results were in the chart when the first dose was given, but nobody took those 6 clicks to find this particular result. They probably didn't even think about looking. And so this patient really should have got a way reduced dose, and it could have really avoided a lot of those severe adverse drug events he had. So what are we doing? What does CPIC try to do? And this was in 2017. We pulled together a community again. I think we had over 90 members that participated in the study. It was important for us to have a very large group of individuals participate in this consensus study because we felt like it might help with uptake if they were invited to be a part of this process. And so what this group did is we had multiple phone calls, multiple surveys, and so we all decided on standard terminology for drug metabolizing enzymes, transporters, and then genes like HLA. And we did come to consensus finally. These are being used in CPIC guidelines. I'm starting to slowly see them being utilized more in the result reporting that I am seeing. We also built and successfully were able to submit these terminologies to SNOMED and LOINC. And so now SNOMED can be used in electronic health records. And so now all these terms are available right there for them. So it's important. So if the laboratory is not using these phenotype terms, it can really slow down that integration into the EHR. So I kind of pointed this out a little bit. Maybe I should have started with this, but this is a big decision tree. There's a lot of things we have to think about when we are reporting pharmacogenomics, but we do feel it's really important that, especially for these important ones like TPMT, NUD-T15, that when you get it to electronic health record, you have a system that will send some type of alert to a clinician if they were to order a drug and the patient had one of these high risk results. It gets more complicated when you've got 2 genes here. And so this is just one of our workflow diagrams that we provide for each one of our guidelines to kind of help guide this process. And so here's an example of what one of those post-test alerts might look like. And again, I stole this right from our EHR here at St. Jude. At least it was a starting place for us to start for this recommendation. But really, again, this can really help make it a bit more efficient to get this terminology, these words written in a meaningful way. And again, yeah, we stole it from St. Jude. I say stole, I was part of that, so I guess we didn't really steal it, but it's certainly helpful to have this information and have it already implemented so that we know that wording, it works great, because we do get feedback from our physicians on the wording where we can change it, and then I can put that back into the guideline. As I said, another area really is genotype to phenotype translation. And actually for CYP2D6, there's another guideline group, the Dutch Pharmacogenomic Working Group. We do work nicely alongside them in some cases, but we were not defining our genotype to phenotype in the same manner. So you can see the patient's a normal metabolizer, this activity score of 1, CPIC would have called it normal. However, the Dutch Pharmacogenomic Working Group, they would call it an intermediate metabolizer. So you can imagine how confusing this could be for users if they're looking and using both these guidelines. And so we got our groups together. So you can see this is a joint consensus statement from both our groups, where we got both our groups together, and we came up with a system that we've all approved, but utilizing this activity score system, which I won't go into a lot of detail here. But this has certainly improved at least the translation of genotype to phenotype for CYP2D6. And we're working, and we did kind of the same thing. We didn't really, we don't have a separate publication for this, but we did the same thing for CYP2C9. We just added it to a guideline. But we're still not there. So it's not just the standardization that really still is a big barrier. It's also reimbursement. I think it's the reimbursements all over the place. But I think this is changing. I'm hearing that that groups or implementers are having a little bit more success of getting payers to reimburse for genetic testing. And this is partly due because MolDX, which is an influential program with really the mission to establish coverage and reimbursement for molecular diagnostic tests, but this is mostly for it is for Medicare. They came out with an LCD and or a local coverage determination, posted it online and asked for feedback. So, and this was a LCD that was targeted at pharmacogenomic testing. And so we get on a CPIC call. We have over 200 members that call into our monthly calls. And we had quite a few members that submitted feedback to MolDX about this LCD, including a committee through CPIC. And when it was finally released, there was some consideration for not only drugs and genes that are in the FDA label, but also for our CPIC level A and B genes and drugs. There are some caveats there. Can't really use it preemptively. You have to really be prescribing the drug before you can order the test. But at least that's a step in the right direction. And we're hopeful, and we are seeing some uptake of pharmacogenomics in more commercial insurance companies, but it's slow. It's a slow process, but I do think that we're starting to see a bit, I think we're winning here. I think that we're going to see a bit more coverage in the future. So where's CPIC going? So we're going to continue to do what we do best. We're going to continue to facilitate the adoption of pharmacogenomics through our clinical practice guidelines. I have a few more standardization projects that we'll be working through that may be a little less aligned with reporting and maybe more aligned with a laboratory, laboratory standardization. But we are still really hoping to help move this along by these standardization projects. But one thing that we're doing that I think is going to be pretty important is better integration into ClinGen. So remember, ClinGen is that authoritative central resource that defines clinical relevance of genes and variants for genetic diseases. Therefore, their SOPs are really specific to genetic diseases. But this may be a place where someone in a clinical lab might go if they're doing some type of sequencing. They find a variant in CYP2C19 and they go here, they put in CYP2C19, and there's really not a lot of data there, and they may not report this back, even though it could be incredibly important for that patient. So it's important, I think, that we get CPIC better integrated into ClinGen, and because of this, we formed a formal partnership with ClinGen. This was a few years ago, and of course, Pharm.D KB, for us to work and start thinking of solutions to get us better integrated. So this is what it looks like now. If you were to go in and put CYP2C19 into ClinGen, now at least you get something. So we were able to accomplish this. So at least there will be some information if someone were to search for CYP2C19. You click on the guideline, it goes straight to the guideline page. And of course, you have to click all these links, and someone who may not be familiar with CPIC may not quite understand how to utilize that guideline. So we think it's better that we are a bit more incorporated into ClinGen. But remember, ClinGen is really disease focused. And so this is just showing you their variant annotations, and they use these terms benign, likely pathogenic, and pathogenic. And I hear a lot of feedback. Please don't use this terminology. If we're going to move in this direction, this would be confusing to our patients because it's a pharmacogene. Really, you have to have the variant and get the drug before you have the side, and you may not even get the side effects. So we think it could be incredibly confusing to not just clinicians, but also our patients if we use this terminology. The other thing we have to think through is our variants. Pharmacogenes really deal with alleles, not just variants. Most of ClinGen, they look at individual variants, where we really are working with more haplotypes or the full allele. But also our allele classification is directional, and diplotypes are incredibly important for defining that phenotype. So how we do this is that, first we have a whole group that assigns what we call an allele clinical function. We can have an increased function, a normal function, decreased function, no function. And it really is that combination of those functions that really define that phenotype. So for example, this individual is carrying one normal function allele and one no function allele, so they are an intermediate metabolizer. So this is very different than they do it in the diplotype world, mostly because of the directionality and the fact that we really use diplotypes to help us better inform what that phenotype might be. And I will tell you, we've got a 50-page SOP that we follow for this process. So it's no easy process, a lot of documentation, but it is something that is incredibly important to the guideline. But because our, really these ClinGen frameworks that are really great, I'm on a ClinGen committee now, and we're working through G6PD, and I'm just amazed by how incredibly efficient they really are at this work. But these frameworks really don't work well for pharmacogenes. And because of this, this group is being led by Terry Klein and Michelle Roll-Carrillo out of Stanford. We put together this working group where we're working through coming up with new tiered standard terminology. And again, this is where we've tapped into our community. We've got several people that willingly volunteered to do a lot of work to get this work done. We have made actually an incredible amount of work that we've done, but we finally are starting to see the end of this. And hopefully we'll have something to present out to the larger community soon. But again, I think I stated this already, there's still a lot of work for standardization before we can really get there. I'm hopeful that maybe getting this into ClinGen might help with that a bit. And this is the editorial that I wrote, or we wrote a couple of years ago, last year, where it's pharmacogenomic implementation, a little less conversation, a little more action, please. Yes, I quoted Elvis. I am from Memphis, grew up in Memphis. Elvis has been a huge part of my life, my entire life. And actually, there's another quote from Elvis in this paper, but the paper really describes, where are we with standardization, kind of an update to that paper I showed earlier, and really how this is impacting how we are reporting and pharmacogenomics uptake. And there's also another Elvis quote in there, as I said, but you'll have to read the paper to see that one. All right. So just to summarize, pharmacogenomics can be used as a patient safety intervention to increase the safe and use of medications. Can't really ignore some of these results. Our patients are going to be coming to our physicians. They already are with these test results in hand. And we really have to do a better job of training our clinicians to understand how to interpret these tests. CPIC guidelines, I think, is the step in the right direction, because it really helps us overcome this major barrier of how to interpret that test. And again, standardization is going to be incredibly important for us to move forward. A big thank you. We would not be where we are without the really enthusiastic members that we have that are very passionate about pharmacogenomics. It's not really about just wanting a piece of the pie. I think a lot really truly believe in how this could really help us decrease adverse drug reactions and really less efficacy of our drugs as well. If we were to implement this maybe more preemptively. I've got a nice staff here, and of course my co-PI, Terry Klein, who was one that started CPIC back 10 plus years ago. We wouldn't be here without her leadership as well. So I will conclude there and happy to take any questions.
Yeah, feel free to put your questions in the chat, and I can read those off for Dr. Caudle. As we're waiting for questions, I want to remind everyone that the MPRINT annual meeting is in May 20th to 22nd in Bethesda, Maryland. The registration will be going out soon, so watch your email for that. And there will also be updates on the MPRINT website that'll have all the information with the conference schedule and hotel and all the logistics things too. Are there any questions for Kelly today? And if we want to put a plug in for Kelly's meeting too, the CPIC is having a meeting in Philadelphia in June. Is that correct?
Yes. Yes.
And all that information is on the website for the CPIC website too. So if you're more interested in getting interested in pharmacogenomics, that's a good meeting to go to too. So, all right. Well, with that, if we don't have any questions, we can just adjourn a little bit early. Thank you so much, Kelly, for your presentation.
All right. Thanks. Bye.